You see, you can start, sir, live. You can start now. Live started.
Kalyan, go ahead.
Sir, sir. Good morning, everyone. Today we are going to discuss about management of traumatic brain injury as per the latest BTF Brain Trauma Foundation guidelines. The latest guidelines are from 2020 and 2023. So, in the next coming slides, we'll be discussing how to manage traumatic brain injury. So, coming to traumatic brain injury, encompasses a broad range of pathological injuries of the brain, varying in clinical severity that results from a head trauma. So, uh, head trauma is that is evident on physical examination, but TBI it is not evident by clinical examination. It's not always clinically evident. So, even when there is no external head injury, there is a high possibility patient might have a TBI component. So, what are the etiologies for traumatic brain injury? Most commonly, motor vehicle accidents, falls, assaults, and sports and recreational injuries. Coming to grading of the traumatic brain injury, we have three grades: mild, moderate, and severe. The components we'll be looking at is GCS, loss of consciousness, and amnesia to the event. So, in mild, the GCS will be 30 to 15. The loss of consciousness for the event is less than 30 minutes and amnesia for less than 24 hours. And moderate grade of TBI, the GCS will be 9 to 12 and 30 to 40, 30 minutes to 6 hours of loss of consciousness. And amnesia will be 24 hours to 7 days. And in severe TBI, the GCS is less than 8 with loss of consciousness more than 6 hours and amnesia to the event more than 7 days. So why it is important to know the severity of the TBI? So the complications and the prognosis will be very bad in severe TBI. Coming to when the patient has a traumatic brain injury, there are two components. Patient will be having a primary brain injury as well as a secondary brain injury. So the primary brain injury is because of the direct impact of the trauma on the brain. So it is because the direct impact, or it is because of the rapid acceleration and deceleration, penetrating injury, and blast phase. What are the primary injuries? Most commonly, they can be contusions, they can be hematomas, EDH, SDH, and there can be diffuse axonal injury and cerebral edema causing swelling of the brain. And what are the secondary brain injuries? Secondary brain injuries is because of the consequences of the primary brain injury. There will be secondary damage to the neurons, and because of the excitatory neurotransmitters like glutamate, causing free radical injury to the cell membranes, and there will be electrolyte imbalance. There will be inflammatory responses causing mitochondrial dysfunction, finally leading to apoptosis of the brain cells. So, and there can be secondary ischemia from vasospasm, focal microvascular occlusions, and vascular injuries. So the main aim of managing the TBI, we cannot prevent the primary brain injury from that trauma, because uh, we cannot change that outcome, but we can prevent secondary brain injury by following certain measurements. So the main aim is to control the secondary brain injuries. So, according to Monroe Kelly doctrine, the intracranial, the brain is encompassed in skull, which is a fixed space. And in the intracranial contents are also fixed. Like the brain is compromised of 83% and the blood volume is 6% and CSF is 11%. So in the intracranial components, the expansion capabilities are very less except for the uh, foramina magnum. So whenever there is an extra mass or extra bleed happens inside the brain because of the trauma or any other thought, there will be increase in intracranial pressure. So at certain point, there will be compensation by uh, decreasing CSF fluid in the brain or decreasing the venous blood. But at particular point, that compensation will be lost and there will be raising intracranial pressure. So what are the interventions that can be done to prevent this rise in ICP? We'll be discussing in the coming slides. So any patient with trauma, polytrauma with its TBA, so evaluation is like A, B, C, D, E, F. E. A for airway and airway securing and with cervical spine immobilization. B for breathing and oxygenation. C for circulation and hemorrhage control, D for disability and exposure. We'll be checking all these primary steps in all patients of trauma. Along with that, we have to check for GRBS in all unconscious patients, can be hypoglycemia induced. And most of the trauma patients are under the influence of alcohol or other substances. So time should be given in patients in case of nutrition deficiency and other drugs intoxication. We can try coma cocktail, that is 25% dextrose, thiamine, and naloxone in these patients who are unconscious. So coming to what are the other steps apart from the initial management, what are the other types of therapy that are used in traumatic brain injury to reduce the ICP? We have three types, type 0, 1, 2, and 3. So initially patients, whatever the severity of TBI, all the patients should receive this type 0 therapy. That is head and elevation to 30 degrees, maintain neutral position of the head to avoid the jugular vein constrictions, and maintain serum sodium more than 150 milliequivalents with isotonic fluid and maintain normothermia. So each intervention we'll be discussing in detail later, but initially what are the different types I'll be letting you know. So in this type 0 therapy, every patient with trauma TBI should receive this interventions. Coming to type 1 intervention should be added in patients whose GCS is less than 8. If the patient GCS is less than 8 and if he is not maintaining airway, we have to intubate the patient. We have to maintain the oxygen levels, PaO2 is between 80 to 120, and maintain the carbon dioxide between 35 to 40. Consider ABG and to correlate with the ETCO2. And come to systemic perfusion. So insert an arterial cannula if the patient is having hypotension. Keep an arterial cannula, keep advanced hemodynamic monitoring, and see the patients of the BP. Maintain euvolemia, maintain the MAP more than 65, and systolic blood pressure if the patient is having hypertension. And our target of the BP should be less than 160 mm of HT. If the patient is having hypotension, consider norepinephrine and maintain MAP more than 65 mm of HT. Coming to cerebral perfusion pressure. So, so in this Monro-Kelly doctrine, what is cerebral perfusion pressure? Cerebral perfusion pressure is nothing but mean arterial pressure minus intracranial pressure. The normal cerebral perfusion pressure is more than 60 mm of Hg, and the normal ICP is between 7 to 15 mm of Hg. More than ICP of 15 mm of Hg is proven to be detrimental to the patient. So, associated with poor outcomes as well. So coming to cerebral perfusion, our target of maintaining the cerebral perfusion pressure more than 90 and ICP internal pressure should be less than 20 mm of Hg. We have to consider invasive ICP monitoring to all salvageable patients with severe TBI and GCS less than 8 and abnormal CT within 74 hours. So how to measure ICP? ICP measurements, there are different equipments we have. Out of this, most preferred one is EVD, external ventricular drainage. The other things are intraparenchymal bolts, subarachnoid bolts, epidural bolts. These are all can be used to measure the ICP, but the most preferred one is EVD because we can measure the ICP as well as we can treat the raised ICP by draining CSF fluid. So maintain cerebral perfusion pressure more than 60 mm of Hg. If it is less than 60, try to increase blood pressure using fluid resuscitation, using vasopressors. If the ICP is more than 22 mm of Hg for more than 15 minutes, so initially we have to verify the waveform whether it is correct or not and level the ED at external artery reactors. Even after that, if the ICP is for more than 22 mm of Hg for 10 minutes, the EVD should be unclamped, leave it open for 15 minutes and close it. If you need to open for more than 3 times in 9 minutes, keep it open continuously and inform the neurosurgeon for further management. So what apart from that EVD, extraventricular drainage, you have osmotherapy to control ICP. So if ICP is more than 22 mm for 10 to 15 minutes, First line, you can give 3% NS a bolus of 500 ml over 15 minutes. If your serum sodium is less than 60, your target sodium should never go beyond 160. Alternate to 3% NS is mannitol, 20% mannitol. If I 70% mannitol, dose of 0.25 to 1 mg per kg. If your serum sodium is less than 160 milliliters, you have to monitor serum sodium every 4th hourly, and serum osmolality should be measured. If we are giving mannitol, if it should be less than 320 milliosmoles. Sorry. Not serum sodium should not change more than 2 milliequivalents in 4 hours. Hold serum 3% NS hypertonic saline. If your serum sodium is more than 1 milliequivalents, and hold mannitol. If your serum sodium is more than 160 milliequivalents, serum osmolality more than 320 milliosmoles. Coming to if even after using all the tier 0, tier 1 and tier 2 measures, if patient is having still raised ICP, what are the next step? How can we manage if ICP is more than 22 mmHg for more than 60 minutes? After using all the tier 1 and tier 2 measures, you can consider CT brain in this patient to see for any space occupying lesion, see for any worsening bleed or increase in EDH or SDH. You have to consider EEG to rule out non-conventional status efficacy in these patients. And you consider giving a burst of analgesia and sedation and increase the dose of sedation. And you can even try paralytic agents if the patient continues to have increased ICP. And before starting paralysis, make sure that patient is completely sedated. Richmond agitation sedation score is -5. Even after giving a bolus of osmotherapy or increasing sedation, ruling out other causes of increased ICP. Even if the patient sustained to have increased ICP, we go to tier 3 measures. We ensure that serum sodium is up to 160 milligrams. Before we maintain less than 160, but even we maintain now we try to reach it to a value of 160 and increase the threshold of ICP to 25 mmHg, and adherence of a cerebral perfusion pressure should be more than 60. So to maintain a cerebral perfusion of more than 60 mmHg, you have to increase your MAP, because we have increased our threshold of intracranial pressure to 25. You have to increase your MAP to a higher level to maintain the cerebral perfusion pressure of more than 60 mmHg. And surgical decompression, decompressive craniotomy is one thing we have to think in tier 3 management. And barbiturate coma. If patient is not a candidate for decompressive craniotomy and refractory to all about tier 1 and tier 2 and tier 1, tier 2 measure, then we can consider barbiturate coma in this patient. But patient should be hemodynamically stable. So let us discuss in detail why we are doing one particular intervention to decrease ICP. Coming to blood pressure, the cerebral perfusion pressure is maintained by mean arterial blood pressure and also ICP. In patients TBA, the ICP is going to be on a higher side. So you have to avoid hypotension. You have to maintain adequate mean arterial pressure to maintain the cerebral perfusion, which will help in maintaining adequate blood supply to the brain and also oxygen delivery to the brain, which will prevent further neural damage. Secondary neural insults help in preventing the secondary brain injury. So your target blood pressure is, if patient is having hypotension, your target blood pressure will be systolic blood pressure more than 100 mm of Hg in age gaps between 50 to 69 years, and it's more than 110 mm of Hg in patients between 15 to 49 years and more than 70 years. The goal is to maintain the CPP of more than 60. If you're not able to maintain your blood pressure, use judicious amounts of fluid. Preferably crystalloids 0.9% NS. Even you can use 3% NS boluses in case of TBA to maintain the blood pressure. If even with the adequate hydration, if you are not able to maintain the blood pressure, please try considering norepinephrine to increase the blood pressure. So in patient with TBA, there will be catecholamine surge, and it will lead to increase in blood pressure, hypertension, which hypotension is also worse, as well as hypertension. Blood pressure on the higher side is also detrimental to the patient. It can worsen the cerebral edema, and it can further increase in ICP, which will be a vicious circle that will further damage the brain. So our target is to maintain the systolic blood pressure less than 160 mm of Hg. If patient is having hypotension, use beta blockers. Beta blockers showed to increase the lowering the mortality in patients versus not using beta blockers. Coming to cerebral perfusion pressure, we have already discussed. We have to maintain adequate cerebral perfusion pressure between 60 to 70. More than 70 is not required. It will lead to increased overload and further worsening of the patient. It can have an effect on cardiac as well. With less than 60, there will be decreased blood flow and cerebral ischemia, which will cause secondary brain injury. So our target, if ICP intracranial pressure more than 15 mm of Hg is independently associated with increased mortality, the goal is to maintain less than 22 mm of Hg. So ICP, in which subset of patients we have to consider invasive ICP monitoring? All salvageable patients with TBI and abnormal CT, patients with severe TBI and normal CT, and age more than 40 years, unilateral or bilateral posturing, and systolic blood pressure of less than 90 mm of Hg. And patients with TBI who will not be examined for long period of time. Most of the patients of TBI with severe TBI, they will be on analgesia, sedation, and some patients might even be on paralytic neuromuscular blocking agents. So in this subset of patients, regularly examining the patient for GCS is not possible, and we have to depend on other parameters. So in this subset of patient, continuous ICP monitoring would give us a guide which help us understand early if there is any further worsening of neurological status, whether they need a repeat imaging or they need other surgical management. We can know early by invasive ICP monitoring. So we have discussed EVD is preferred in ICP monitoring. It helps in both monitoring and CSF drainage. So EVD can occur for ICP as well as EVD with continuous drainage will lower ICP more effectively than intermittent drainage. So patients with severe TBI requires control wedge. This one we have discussed with muscle relaxant. So evidence. What is the evidence? Whether this ICP, invasive ICP monitoring in patients, did it help in improving the patient outcomes or not? Did it improve the neurological functioning of the patient or not? The recent evidences like Alali et al., Davos and Roba et al., these studies have showed that there is an using invasive ICP monitoring, there is an increased in improvement in mortality, there is an improvement in neurological outcome. But later studies like Kramer et al., Shafi et al., Chestnut et al., and Eller et al. did not show the same. There was actually there is even a worsening of the functional status. There is no neurological impairment. There is no mortality benefit or using a ICP monitor. Even patients with ICP monitoring have further complications like more of infectious complications has been observed. So what are the from the studies, there is no potential benefit of ICP monitoring in severe TBI still remains unclear, as observation studies have shown conflicting results. Earlier studies showed an improvement, but later studies did not reflect the same. So one of the large RCT that evaluated the potential benefits of ICP monitoring did not demonstrate any clinical outcomes compared to management based on clinical and CT imaging. As clinical assessment is often impractical as they are sedated and paralyzed. Continuous on ICP monitoring enables early identification of neurological deterioration and may facilitate appropriate therapeutic intervention. So regular ICP monitoring may not be required. There is no benefit of use, but in patients in whom we cannot assess the sensorium regularly, in the such subset of patients, ICP monitoring may be beneficial, which helps in identification of early neurological deterioration. Coming to head end elevation, the patients should have a 30 degrees head end elevation. This will help in draining of your cerebral venous circulation, decreases the cerebral edema, and lowers the ICP. In patient with cervical spine injury, we can use reverse Trendelenburg position. More than 30 degrees elevation did not demonstrate any beneficial. So 30 degrees elevation should be used in all patients with traumatic brain injury. Coming to fever. fever is considered when a body temperature is more than 38.3 degrees, that is 100.9 degrees, which is seen in more than 70% of TBI patients. But if they have higher temperatures more than 37 degrees, already there is a trauma to the brain, and there is a secondary brain injury that is happening, and increase in temperature may further have a secondary impacts on the brain, impaired brain parenchyma. With increase in temperature, there will be increase in inflammatory response, increase in pro-inflammatory cytokines, neutrophils, increase in sympathetic tone. There will be increase in resting body expenditure and oxygen consumption, heart rate, and minute ventilation. So everything will further have an impact on your brain that will increase your cerebral edema, will further worsen your ICP. So controlling your body temperature is very important in patients with TBI. Even a slight increase from the normal body temperature is also detrimental. So in patients with TBI, there is a central cause of fever. It is due to the damage of the thermoregulatory centers of the brain, that are those are preoptic nucleus of hypothalamus and focal centers of the pons. So damage of these centers will further there will be loss in thermoregulatory mechanisms. So and the patient will still have a higher temperatures, which are not responding to your regular fever management. So significant worse outcomes are seen in patients who develop fever within 72 hours. And what are the causes of fever with low GCS? There could be a diffuse axonal injury. There could be cerebral edema, hypotension, hypoglycemia, and leukocytosis. Fever within first week is associated with increased ICP, neurological impairment, prolonged ICU stay. What is the treatment? Aggressive cooling efforts to cool temperature using antibiotics, cooling room, and cooling blankets has to be done. So, high temperature is detrimental to the patient. As so, by cooling the temperature, by reducing the body temperature, coming down to 33 to 35 degrees, it has shown initially some benefits. What are the mechanism of mechanism by which hypothermia reducing the secondary brain injury to the brain? Hypothermia reduces the formation of oxygen-free radicals and inhibit excitatory amino acid release. It will also reduce a large influx of calcium into the cells and inhibit the release of the inflammatory mediators. And it will reduce the cerebral metabolic rate, and it will reduce the oxygen consumption by the brain, approximately 6 to 10% for each degree of Celsius decrease in temperature. It also suppresses the nitric oxide expression, and it also have protective effects on the blood-brain barrier. So decreasing the temperature of the brain, decreasing the temperature of the blood has some protective effects, but it did not translate into the clinical benefit to the patient. So theoretically, we have some beneficial effects by decreasing free radicals, decreasing calcium influx, oxygen consumption, finally decreasing the apoptosis of the cells. So what are the methods of cooling? We have IV salines infusion at which is cooled at 4 degrees, and other things are endovascular cooling devices like central venous heat exchange catheters, surface cooling like circulating blood, cold water blankets, cold air blankets, pads, intranasal cooling, rhinochill for selective brain cooling. So inducing hypothermia, it did not show whatever the benefits we have seen before. It did not, but it has not been demonstrated to improve the long-term outcomes in cases of 3 months or 6 months after the injury. By inducing hypothermia, we have seen complications like patient can develop hypertension. There can be electrolyte imbalance, impaired coagulation is there, coagulation abnormalities is seen, and shivering, hyperglycemia. By hypothermia, there is decreased insulin production, and patient will have hyperglycemia, and there is increased risk of infection because there is immunosuppression. These are the complications of hypothermia, cooling the patient to 33 to 35 degrees. These are the initial evidence, Mariton et al., Jiang et al., and G et al., where initially they have studied that hypothermia in these trials showed to be beneficial. There has been favorable outcomes, favorable neurological outcomes, but later studies failed to show the same. Clifton et al. And Mika et al. In this, there is increased complications, increased morbidity of the patient. There is no significant improvement in the neurological outcome in these trials, and these trials also showed the same. So coming to discussions, that early RCTs revealed that potential of improved neurological outcome. However, the larger RCTs have consistently failed to establish beneficial effects of therapeutic hypothermia in severe TBA. So hypothermia is not beneficial to the patient, as well as therapeutic hypothermia is also not beneficial to the patient. So preventing hyperthermia is the mainstay of treatment. You have to prevent the patient from increasing the temperature rather than actively cooling the patient to less than 35 degrees temperature. So for maintaining this, now the mainstay is targeted temperature management. You have to prevent the hyperthermia to happen rather than going into a lesser temperature. So what are the cooling measures we have seen? And there are complications like shivering. Shivering is the major complication while they are trying to maintain the temperature in the temperature of the patient. So when body's temperature is lowered, physiological response to prevent the heat loss is through vasoconstriction and also shivering. So what are the measures which can be done to control the shivering? Because shivering will further produce heat, which is detrimental to the patient. We should try to control shivering. We have benzodiazepines. You can use fentanyl, magnesium, mepridine, morphine, neuromuscular blockers, and bispirone can be used to reduce uh, shivering and prevent the increase in body temperature. Coming to seizure prophylaxis, there in post-traumatic patients, there are two types: early seizures and late seizures. If the seizures are occurring within the 7 days of trauma, it's considered as early. If it is more than 7 days, it's considered late seizures. Both early and late seizures should be avoided. What we have, levetiracetam and phenytoin can be used to prevent the early post-traumatic seizures in severe TBA, but not in mild or moderate TBA. A routine prophylaxis for late post-traumatic seizures is not recommended. Seizure prophylaxis can be discontinued after 7 days of therapy in the absence of seizure activity. So coming to hyperventilation, is there any role of hyperventilation in preventing uh, in decreasing ICP? As of latest evidence, there is no role of hyperventilation. It should not be used in patients with in acute TBI at least, because already the patient's circulation is compromised because of raised ICP. By hyperventilating the patient, washing out of CO2 further causes vasoconstriction in brain, which will further worsen the blood supply, which is more detrimental. So it should be avoided in the first 24 hours post injury. So, and prophylactic hyperventilation is no longer recommended. So the target of PCO2 should be PaCO2 should be between 30 to 35 to 40 mm of mercury. So if there is a refractory elevation of ICP, even after tier 1 and tier 2 measure, if there is refractory elevated more than ICP is more than 22, then your target can be decreased to 30 to 34. But this hyperventilation has a role as a temporizing measure in acute reduction of elevated ICP, but you under the monitor of SGVO2 or brain tissue oxygenation should be considered. Only in dire situations when ICP should be reduced, then only you have to use hyperventilation, but that also using other advanced brain monitoring. What is the cause for cerebral edema in patients with TBI? So it can be occurred due to disrupted blood-brain barrier. It can be occurred because of the inflammation, vascular increased blood pressure, increased vascular supply, or due to altered cerebral cellular metabolism. So how to decrease the cerebral edema? We have hyperosmolar agents. We have the most commonly used are hypertonic saline and mannitol. So depending on what is the reflection coefficient, the permeability of a solute across the blood-brain barrier depends upon its reflection coefficient. For if it is 0, it's completely permeable, and if it is 1, it's totally impermeable. For sodium, it is 1. So sodium is totally impermeable at blood-brain barrier, whereas for mannitol, it is 0.9. When there is a disruption of blood-brain barrier, there is a high chance that mannitol can cross blood-brain barrier and can be deposited in the brain parenchyma. So what is the mechanism of action of this hyperosmolar therapy? So by increasing the osmolarity of the blood, we are shifting the blood fluid from the brain parenchyma to intravascular compartment, thereby reducing the cerebral edema and reducing the intracranial pressure. And the other component is improving the rheological properties of the blood. Rheological properties, by increasing the serum osmolarity, there will be fluid shifts from the brain parenchyma, as well as there will be fluid shift from the erythrocytes into the intravascular compartment, reducing the viscosity of the blood, improving the oxygen delivery to the brain, improving the uh, uh, preventing the further damage. So these are the rheological properties. So it will reduce the ICP and it will increase the cerebral blood flow, reducing the oxidative stress and inflammation to the brain. So we have the hypertonic saline or mannitol for as to reduce the cerebral hyperosmolar therapies. So hypertonic saline has more benefits. It has a faster onset of action, more robust and sustainable decrease in ICP. It can also we can also give hypertonic saline as a fluid bolus to increase in the blood pressure and maintain the cerebral perfusion pressure. It 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 decreases the cerebral edema. It simultaneously increases cerebral perfusion pressure by increasing the MAP. So what are the different options of the hypertonic saline? We have 3%, we have 7.5%, and 23.4%. 3% NS, the sodium content is 530 millimoles, whereas 23.4% NS is 4,004 millimoles. So using 3% NS as a resuscitation fluid in hypertensive TBI patients were twice likely to survive when compared to those who received 0.9% NS. And 23.4% NS, 30 ml over 15 minutes is best used to refractory elevated ICP. What are the complications of hypertension? Hyperchloremia with metabolic acidosis, increase in sodium which can cause central content malnutrition, cause acute. Coming to mannitol, its dose is 0.25 to 1 mg per kg, should be given every 6th hourly. It should not be administered without ICP monitoring unless the patient shows signs of transtentorial herniation. Serum sodium and serum osmolarity should be measured every 6th hourly. Goal is to maintain serum sodium less than 160 milliequivalents and osmolar gap, that is measured osmolarity minus calculated osmolarity, should be less than 20 milliosmolars per kg. So mannitol acts by mainly two mechanisms of action: osmotic gradient and rheological effects we have discussed before. What are the side effects? It has water electrolyte loss imbalance can be happen. If blood-brain barrier is broken, it can extravasate into interstitium. It can further worsen the cerebral edema. And renal failure patient, we cannot use mannitol. It can cause AKI because of the high concentration of mannitol and increased serum osmolarity. So what are the evidence which suggested hypertonic saline is better? There is a case control study compared hypertonic saline with 20% mannitol in TBA. The total number of days with high ICP and low cerebral perfusion pressure was significantly lower with hypertonic saline. And Schwimbeck et al. Found a meta-analysis of 12 hours. There is a non-significant trend towards lower mortality is noted with hypertonic saline. ICP levels were significantly lower between 90 to 120 minutes with hypertonic saline. Better ICP control and improved cerebral perfusion with hypertonic saline. Coming to DECRA, decompressive craniectomy. So when your tier 1 measures and tier 2 measures fail to reduce ICP, so we consider decompressive craniectomy in the patients. So what is DECRA? It involves removing a sufficiently larger segment of the skull to relieve the ICP in patients with intracranial hypertension, despite the first and second tier medical therapies not functioning. So what are the types of DECRA? It has bifrontal bitemporal DECRA. A surgical technique include durotomy and duroplasty. In 2007 TBI guidelines, based on these trials, Jin et al. And Q et al., they have observed patients who underwent decompressive craniectomy has a good neurological recovery at 6 months. So in this initial 2007 TBI guidelines, they advised to consider decompressive craniectomy in cases of refractory increase in ICP. In 2011, Cooper et al. Observed between decompressive craniectomy versus standard care. Decompressive craniectomy has patients who underwent decompressive craniectomy has mean lower ICP after surgery, but the primary outcomes and the functional status Glasgow outcome scale was worse in surgical group. Decompressive craniectomy group had a significant higher proportion of unfavorable outcomes. Mortality is similar between the two groups. The later studies did not improve any neurological outcomes. There is a reduced ICP, intracranial pressure, but the functional outcomes, patients are more of vegetative, they're more of a dependent, they have other complications, but the outcomes were lower in case of decompressive craniectomy group. So the latest guidelines, DECRA, which was done over 8 years, and Rescue ICP. So these studies in DECRA, what they have seen is the bifrontal decompressive craniotomy versus medical management in severe TBA. In DECRA, they have taken for early DECRA, that is ACP more than 20 mmHg for 15 minutes over 1 hour, despite tier 1 treatment within 72 hours. They have taken patients for decompressive craniectomy within 72 hours, despite of all the other measures, if the ICP is on the higher side. So what they have observed is lower ICP is observed in post-surgery patients, fewer days of ventilator and ICU, but there is no difference in mortality. And at 6 months and 12 months, it tend towards worse functional outcomes has seen in patients who underwent decompressive craniectomy. Coming to Rescue ICP, in this they have taken patients for decompressive craniectomy as a salvage therapy, even after tier 1 and tier 2 measures. Highest level we have tried, but even after that, ICP is still on the higher side. Then they have taken for decompressive craniectomy versus medical. What they have observed is, now in this patient, they had ICP more than 25 mm of Hg for 1 to 12 hours, refractory to second tier 2 management within 10 days of admission. The mortality is lower in surgical group. However, higher rates of survival with vegetative state and severe disability has been seen in patients who underwent decompressive craniectomy. Decompressive craniectomy helps to reduce ICP, but why why there are no improved outcomes in this subset of patients? We are trying to reduce ICP by doing a decompressive craniectomy, but that the ICP reduction did not translate into the improvement, clinical improvement in the patients. What could be the possible reasons? After decompressive craniectomy, the axonal stretching that occurs after the brain swelling outside may lead to further worsening. That might be one reason. There is still stretching of the brain, and there can be axonal damage that can cause further worsening, secondary damage to the brain. If you are doing a relatively small decompressive craniate, small DECRA, there is a probable that brain that is coming out of the DECRA and the surrounding part of the brain, which is not bulging, that can have a hypoxia because of the compression effect of the bone defect. Too large DECRA may also be harmful. So these might be the reasons, even after reducing ICP, why there is no improvement in the outcomes of the patient. Coming to, so in International Brain and Trauma Foundation 2020 have given a guidelines when to take for DECRA. So decompressive cranectomy. Decompressive cranectomy performed for a later refractory ICP is recommended to improve mortality and favorable outcomes. And decompressive cranectomy performed for early refractory ICP elevation is not recommended to improve the mortality and favorable outcomes. A larger frontotemporal decompressive craniotomy is recommended over a smaller one. And decompressive craniotomy performed as a treatment for either early or late ICP elevation is suggested to reduce ICP and the duration of ICU stay, though the relationship between these effects and the favorable outcomes are uncertain. What are the key points? So the role of decompressive craniotomy after severe traumatic brain injury remains uncertain. It should be considered in carefully selected patients and only after discussing with the family about the possible poor outcomes. And there is no role of early decompressive craniotomy, but a possible role after maximizing other therapies for intracranial hypertension patients who have no other adverse features that suggest of poor prognosis. So what are the other things? So coming to hemoglobin resuscitation, restrictive RBC transfusion threshold of less than 7 grams is commonly used in IC based on transfusion requirement in critical care, right? So they which did not show any benefit of higher threshold more than 9 grams. So we generally follow transfusion trigger of less than 7 grams. So, but there is a theoretical benefit of maintaining elevated hemoglobin concentration in TBI patients who are at risk of developing cerebral ischemia, already compromised brain with increased ICP. There is a theoretical benefit. And Chacon et al. Have recently conducted a retrospective cohort study of 273 TBI patients where he identified a mean hemoglobin of less than 8 grams DL during the first
Kalyan,
8 grams.
Kalyan, you seem to have an unstable connection.
Hello, sir. Hello,
Yes, Kalyan, go ahead.
sir. Sorry, sir.
That's okay. Reshare your presentation.
Uh, the advantages of
Kalyan,
Hello, sir.
Yeah.
There is some issue with this thing.
okay, can you reshare the presentation?
Yes, sir. Yes, sir. Just a second.
Hmm.
Sir, is it visible, sir?
Yes.
Sir, coming to neuromuscular blocking agents, it is beneficial in controlling of refractory raised intracranial hypertension and reducing cerebral metabolic rate. Whereas prophylactically paralyzing the patient is associated with increased incidence of pneumonia and ICU stay. So it should be used only after failure of the other therapies. Coming to barbiturate coma, high doses of barbiturate helps in reducing the ICP. The prophylactic administration of barbiturates to reduce the ICP and to induce burst suppression in EEG is not recommended. It is recommended only after the initial tides of therapy was given. Even the ICP is elevated, which is refractory to other medical management. What are the side effects of barbiturate coma? It is hypertension. So advanced hemodynamic monitoring is necessary. So pentobarbital coma, the dose is 10 mg per kg over 10 minutes, followed by 5 mg per kg for 3 hours. Later 1 mg per kg for IV infusion. Titrate to minimal dose requiring to achieve the burst suppressions and consider invasive hemodynamic monitoring. If once the ICP is less than 22 mmHg for 88 hours, wean over the next 48 to 72 hours. If you are unable to maintain the ICP less than 22 mmHg for at 72 hours, discuss regarding discontinuation of this therapy. Decrease feeds to tropic feeds at this point of time. So patients with TBI, they have increased hospital stay, increase in ventilator days, multiple invasive lines. Their bedridden, they are mostly prone for increase in infection. They are susceptible to infection because of multiple reasons. So in this patient, early tracheostomy is recommended, though it has not shown to reduce any nosocomial pneumonia or overall mortality. Routine ventricular catheter exchange and prophylactic antibiotic administration has not been demonstrated to reduce the incidence of infection in this kind of patients. So DVT prophylaxis. TBI patients are high risk for developing DVT because of the prolonged immobilization, focal motor deficits. And DVT prophylaxis should be initiated within 24 to 48 hours after presentation, once the cerebral hemorrhage has been ceased and brain injury considered to be stable, or after 24 hours of craniotomy. We can use heparin, low molecular weight heparin, or plus or minus mechanical prophylaxis. So stress ulcer prophylaxis, it should be administered using H2 blockers or PPS. Nutrition, early enteral nutrition should be initiated. Patients should receive full calorie replacement by 5 to 7 days. Transgastric or vaginal feeding is recommended to decrease incidence of VAP. So advanced cerebral monitoring like duplex sonography, arteriojugular venous oxygen difference, and local tissue oxygenation can be considered to reduce the mortality and improve outcomes at 3 to post injury. Corticosteroids, there is no benefit in lowering it. There is no role of corticosteroids in lowering ICP in case of TBI. It is absolutely contraindicated in cases of TBI. So in patients with TBI, we have to protect the brain. To prevent the secondary damage to the brain, we have to give judicious analgesia and sedation to control pain and agitation, fentanyl, and rule out seizure activity. On spot EEG has to be done within 24 hours to rule out NCSC if GCS is less than 10 or less. Levipil for 7 days, and discontinue Levipil if there is no
Kalyan,
Sir, I think so.
Hello.
hello.
Hello. Sir.
Yeah, Kalyan, have you
Just
joined?
two. Yes, sir. Yes,
How
I
many?
joined, sir.
Yeah.
Just 2 minutes, sir. I think it is done. So, am I audible, sir?
Yes.
Hello.
Yes, you're audible. Yes, go ahead.
Yes, sir. So, what are the things? What are the things we have to avoid? Avoid hypotension, avoid hypoxemia, saturation less than 92, avoid hypercarbia, PCO2 less than, avoid hyponatremia, hypo or hyperglycemia, hypovolemia, fever, and anemia. So, what are the recommendations? We have level 1, level 2, and level 3 recommendation. Level 1 is do not administer high dose of steroid. Rest are all level 2 indication, and level 3 indications are hemoglobin meant to maintain hemoglobin more than 8 grams, SBP more than 100 mm of Hg, and systolic blood pressure goal of less than 160 mm Hg in case of hypertension. Thank you.
Thank you, Kalyan. I think managing traumatic brain injury patients is always a huge challenge. On one hand, majority of the times you find a lot of youngsters being involved in major road traffic accidents. You can also find a good number of patients who are on multiple medications or with other comorbidities, admitting to the ICUs with traumatic brain injuries. And apart from your specific brain-related issues, which Kalyan has highlighted in detail, I think traumatic brain injury is one scenario where general intensive care also matters a lot, especially your ICU nursing, the way you feed them, because these patients are going to stay with you for quite a long period of time, and maintaining the nutritional needs becomes extremely important. DVT prophylaxis, and many a times, if you see the mortality in a large number of these patients, is influenced by your nosocomial infections. So how good is your infection control practices, and how good are you with preventing nosocomial infections is very, very important. And another key part in managing patients of traumatic brain injury is early rehabilitation. At least our own experience is a good number of these patients, when managed conservatively with good rehabilitative services, regain a very, very decent quality of life. Uh, One point that we often kind of experience in patients with traumatic brain injuries, episodes of sympathetic hyperactivity, which many a times we can confuse with either agitation or a seizure or sepsis. So that's something that we just need to keep in mind. You can have, because of the loss of the inhibitory control, you can have episodes where patients may have tachycardia, fever, agitation, tachypnea, etc. Your TBI patients also kind of test your balancing act between deep sedation and trying to give episodes or periods where you want to do frequent neurological monitoring. Uh, Another point that I would just like to make is, as ultrasound is becoming a key part, in cardiorespiratory monitoring, so has its role in the monitoring of neurological patients has increased significantly. Use of ultrasound for optic nerve sheath diameter measurements, or use of ultrasound for transcranial Doppler is something which can be easily duplicated or repeated at the bedside if you do not have facilities for advanced or invasive ICP monitoring. Uh, I think those are the few points which I think we should keep in mind. Thank you, Kalyan, for a detailed walkthrough with the recent BTF guidelines. Thank you very much.
Thank you, sir.